Hassan, thank you very much for that nice summary of our two papers. And also, those are very thought-provoking questions, and I think we should have a discussion about all of them after the talks. So, as you pointed out, the two papers that are published so far have been related to hormone replacement therapy with estrogen and progesterone to program frozen embryo transfer cycles. And that's the standard protocol in our clinic. I do have some new information to share with everybody based on fresh embryo transfers in IVF. So let's see. So this is 371 cycles of fresh transfers on day 5, so a single blastocyst transfer in IVF cycles. And you can see that similar to the hormone replacement cycles, in the presence of compaction of 10% or more, we had a significantly higher pregnancy rate, or this is actually ongoing pregnancy, live birth rate, compared to no compaction. And then we also looked at modified natural FET cycles. And as you can see, we found the same effect again. So with compacted endometrium, the ongoing pregnancy rate is about double compared to non-compaction. So if we put all 4 of these projects together, that gives us almost 1,000 embryo transfer cycles with a pretty consistent improvement in pregnancy rate with compaction. But I do have to point out that only about 1/3 of the patients showed compaction and about 2/3 didn't compact. So this is not sort of the standard thing that happens in embryo transfers. So if we do believe that compaction is important, are there some ways that we can improve the occurrence of compaction in patients who don't compact initially? So some possibilities that we listed in our first paper include increasing the progesterone dose or the duration of progesterone, or increasing progesterone potency. All of these things would address the issue of progesterone resistance. And we do know that patients with endometriosis and potentially or possibly patients with polycystic ovary syndrome do exhibit some degree of progesterone resistance. And I think that would make sense if the lining is not getting a good secretory change, it wouldn't necessarily become denser and compact. And I have to tell you, in some cases where we see the lining get thicker, the endometrium doesn't actually lose that 3-line pattern. It doesn't become homogeneous. It stays sort of a 3-line pattern, which would suggest to me that you're not getting a very good progesterone response. So increasing the dose, the potency, or the duration of progesterone until you see compaction is one possibility. The other possibility is that it may be a ratio issue between the amount of estrogen and the amount of progesterone. And by decreasing the estrogen dose once you start progesterone, that may facilitate the ability of the progesterone to cause a secretory change in the lining. So typically we do drop our estrogen dose from 6 to 8 milligrams during the estrogen phase down to 2 milligrams. And I must say, in some patients, I've actually taken away the estrogen completely once we start progesterone, and it doesn't seem to cause any problem at all. And then finally, another way to inhibit estrogen production is to add an aromatase inhibitor towards the end of the estrogen phase, which would prevent any endogenous estrogen being produced by the endometrium. And again, there's some data in endometriosis patients that there is aromatase present in the endometrium. And if you inhibit that, you may again change the ratio of progesterone to estrogen in the endometrium, which would give you a better progesterone effect. So I just want to show you one of our protocol sheets. So this is our standard frozen embryo transfer protocol sheet used at TRIO. This is a patient with endometriosis. She's been treated with depolupron and Advac with estrogen and progestin for 2 months, together with letrozole 2.5 milligrams daily. This was suggested by the group at McGill as improving frozen embryo transfer outcome in patients with endometriosis, that is adding the letrozole to the depolupron. This is what we call a short protocol. So we just pick a day to start. We add estrase. Usually we start at 4 milligrams a day, and we go up to 8 milligrams a day over the course of 10 days. Once the lining is thick enough, and I'll show you in the next slide how we decide how thick is thick enough, we decrease the estrase to 2 milligrams daily, and we add progesterone. And in this particular patient, we added progesterone in oil, plus we added crinone twice daily to the progesterone in oil. And then we check for compaction on the day 5 of progesterone. And if the lining compacted, then we go ahead and transfer a single embryo of best quality. So you asked, Hassan, how do you decide when to stop the estrogen? You can, I think it's the thicker probably the better, but what we've done is look at how thick the endometrium gets in the stimulated cycle from which we retrieve the eggs. So this is the same patient. You can see the Gonal-F Menopur stimulation protocol using an antagonist. Because she has endometriosis, I also add letrozole to keep the estrogen from getting too high. And then we did a dual trigger when the follicles were large enough. And you can see her endometrium got to 10.3 millimeters. So in this particular patient, when we do a frozen embryo transfer cycle, giving her estrogen, we would aim for the endometrium to get around 9 or 10 millimeters before we start the progesterone. So that's one way to guide how thick the endometrium should be before you start progesterone. Because if it can get this thick in a stimulated cycle, that means it has the potential to get that thick. So I think I'm going to stop there. We'll talk about some research ideas later on. But I don't know, are there any other questions that you'd like me to answer right now, Hassan?
Thank you very much. A wealth of information. And we will have 5-minute questions. And Professor, we changed the schedule because Professor Bedewi will have to leave in an hour. So Bedewi will present after Professor Casper. So Angie, are there any people who want to ask Professor Casper? Of course, Peter or Bedewi, if you want to start.
Let me start, if I may.
Hi, Peter.
Hello, how are you doing? It's a delight. It's a delight to see you. You look great in the Corona era.
With bad haircuts, right?
Well, both of us 2 months now. Fabulous presentation that we always learn from. So I see on your on your stimulation sheet you're using depolupron still in most of the patients, or you currently move to using in cyclic patients just regular estrogen and progesterone?
Oh yeah, sorry. So that was an endometriosis patient, Boutros. So all our endometriosis patients we suppress for 2 months before embryo transfer. In cycling patients, we just use the short protocol. We start the estrase on day 3. With or without Lupron. Some doctors like Lupron, to add Lupron before. I don't think it makes any difference. I just, if patients doesn't have endometriosis, I just start estrase on day 3.
Lovely, thank you.
Bob, did you stratify your patients who are not compact, who did not show any compaction, to see what is the primary diagnosis of those patients? Because this is a heterogeneous group of patients. So did you try to stratify to see which subgroup of patients that did not compact the most?
No, you're right. It was very heterogeneous. It didn't seem to make any difference. I was sort of hoping that we could pick out the endometriosis patients and sort of show that they had a very high degree of non-compaction, but that wasn't the case. So the only thing that and the other thing we found was that age wasn't a significant issue. So whether the endometrium compacted or not was important, and also the embryo quality was important on multivariate analysis. But BMI, age of the patient, surprisingly, and endometrial thickness. When we started, actually endometrial thickness when we started, or when we ended estrogen, or at the start of progesterone, was also significant. The compaction didn't make any difference if the endometrial thickness was less than 8 millimeters. So if it was between 7 and 8 millimeters, whether the endometrium compacted or not didn't really affect the pregnancy outcome, which was poor. And the thicker the lining was before adding progesterone, the more the chance of compaction and the better the outcome.
So if we consider compaction to be the norm, did it surprise you that 2/3 of the entire patient population that you studied were not compacting?
Yeah, I don't think it is the norm. I think it's a reflection of an enhanced implantation potential. So I think the norm is probably for it not to compact, as we found. But if it does compact, the pregnancy rate seems to be higher. And I really can't explain the results of the Chinese study. I mean, it was a very large study. They found exactly the opposite of what we found. And I think we need to do more research. I think, again, Hassan's question about, what's the molecular mechanism behind this, I think that's very important, and we need to do some work on that.
So how do you feel?
Also, does it mean the end of the implantation or near the end of implantation window compaction? Because if
Can
I complete my question?
Yeah.
If you have endometrium 7 millimeter at day 7, you may continue 5 or 6 or 7 days, and you know that the implantation window is still open. But if you have compaction, you think that this is the end of the implantation window, for example?
Yeah, so the implantation window doesn't start to open during the estrogen phase. You can go as long as you want with estrogen. It's only when you start the progesterone that you start to get into this window of implantation. I actually think the window is wider than people think. I don't think it's 12 hours. I think it's more like 2 to 4 days, actually. And what we found is if the lining doesn't compact after 5 days, but it looks like it's moving in the right direction, we just go 2 or 3 more days with progesterone until it does compact, and then do a transfer, and we get pregnancies doing that. So that either tells us that the compaction tells us when the window is open, or if there's no compaction, we can go longer, and maybe the window is actually longer than we think.
Peter, please.
So how do you feel if you're using mainly estrogen progesterone, like all of us are doing, or estrogen progesterone and lupron, like we all did and still doing in some situation? How do you feel about the recent results suggesting that a mild stimulation with HMG, for example, is more productive in terms of clinical pregnancy compared to estrogen and progesterone? And then part B, if mild stimulation is productive, so what about some patients who have 1 or 2 embryos and maximum, and they've been on high stimulation being 450, mild stimulation being 150? Or do you recommend we stay 100% on just estrogen progesterone?
No, I think there's a place for natural cycle or modified natural. There's some data from China looking at letrozole induction of ovulation for FET cycles. Bruce Lessig showed that letrozole tends to improve endometrial receptivity. So, I mean, that's a possibility. We haven't looked at enough cycles to know what happens with compaction in those cycles. I think there is some data that's going to be presented later at this session about the beneficial effect of maybe having a corpus luteum. Maybe there are some factors produced by the corpus luteum that have a beneficial effect on pregnancy outcome. So there may be some advantage of a natural cycle. In our situation, we still favor hormone replacement because we're busy enough that we need to be able to schedule transfers. And we want to diminish, especially in these days of COVID-19, we want to reduce the amount of monitoring. We don't want the patients in the clinic too often. So the hormone preparation cycles certainly facilitate that because you only need a couple ultrasounds in that situation.
And we're going at the end towards some more questions about standardization. I understand what are currently you using the number of days of progesterone for blastocyst transfer, and if you do any still day 3 frozen thawed, how many days of progesterone do you use?
Yeah, we don't do day 3 anymore. We only do blastocyst transfers.
Right.
We check the endometrium on day 5 of progesterone.
Right.
If it looks good, in other words, if it's compacted, we thaw the embryo on day 5 and we culture it overnight to see if it develops further. So that's another prognostic indicator in our lab. And we transfer the embryos on day 6 of progesterone.
Right. So day 6 being like closer to 144 hours, and day 5 120, or day 5 is between 96 and 120, and day 6 between 120 and 1.
I don't know. I can't figure out the hours that quickly. The day we start progesterone, we count as day 1.
Right. And you start in the morning, like for example, you're doing a transfer on Friday. Do you start Saturday morning or Saturday night or Sunday morning?
Yeah, we start in the morning. Yeah.
In the morning of just a week before. Like I mean, if you're doing Friday, then you do Saturday before. Yeah. Saturday, Sunday, Monday, Tuesday.
Yeah. And we thaw the day before.
Yeah, of course. Yeah. Thank you.
So the first question from Professor Darwish: did you take endometrial biopsy from cases canceled for no compaction?
No, we didn't, but it would be a good idea, I think, to do that.
That's a good idea. For how many days letrozole when you use it?
I've been using it for 5 days right at the end of the estrogen before we start progesterone. And then I stop it when we start the progesterone.
Timing to measure compaction? Day of embryo transfer?
Oh, sorry. No, we now measure on day 5 so we can cancel the thaw if we find that we don't have a pattern that we like. So the 5th day of progesterone is the ultrasound.
Dr. Muhammad Fawzi, did you try to reanalyze the compaction at an ordinal scale level to calculate the proportional odds of its effect on pregnancy?
I don't understand the question.
Muhammad Fawzi adores the statistics, and I don't understand it either. If he has the mic,
yeah,
maybe we can understand him.
Yeah,
he's a very smart guy.
I can
smart for me.
Yeah, I'm happy to translate. So would you consider the endometrial compaction as independent factor when it comes to, let's say, failure to conceive?
It seems to be. We did the logistic regression analysis, and only compaction and embryo quality were related to the pregnancy outcome.
Okay, not that I actually mean. I mean that when we analyzing data like this, we sometimes need to know at what level, because the endometrium will reach the stages where it will compact by 5%, then 10%, then 15%, then 20%, and this is an ordinal scale data, and we need an analytical model to know at what compaction the pregnancy improved, and vice versa. This can be analyzed or can be well presented by ordinal scale or odds, proportional odds of the effect of this study. Also, another question.
Sorry, so let me just address that one because
let us answer first, Fawzi.
Yeah, okay.
We did look at that. We did ROC analysis.
Yeah.
And we found that the sensitivity and specificity was greatest at around 15%, but was positive at 10%. And then it gets, the sensitivity hasn't changed, the specificity goes up with higher compaction.
Okay.
Dr. Barker, stop sharing, please.
Another
question is, please, as this study is retrospective in nature, at some study of not high sample size, as this study of 200 and so participant. Some prefer to do a matching technique to try to make the two group are comparable, so they can do that as a sensitivity analysis for what they found. It seems for retrospective study to draw causation rather than association, and it's more sensitive than the ROC curve.
So I might ask you to help me do that then.
Yeah, no one can help you.
Please.
You can help yourself with him. Fauzi, thank you very much for this complicated question. Another question, how do you clinically identify that you have to transfer in a specific day? And does it differ if you transfer in morning or evening? Does it differ whether you transfer in the evening or morning? It's for Betty and Casper.
Well, I don't think it makes a difference because I think the window of implantation is quite broad. So morning or evening
doesn't make a difference day or night. Any recommendation for PCOS, endometriosis, adenomyosis?
Well, for adenomyosis and endometriosis, I think you can optimize the pregnancy rate by suppressing with GnRH agonist for 2 months before transfer.
I agree with Dr. Casper, but Bob, did you try to suppress with antagonist?
No, because it's too expensive. Do you mean for a long time, or the ganirelix?
Yeah,
not ganirelix.
I'm talking about the elagolix, the oral.
Or Alyssa. Yeah, no, I haven't tried. That could work. It'd be oral daily then.
Yeah. We tried it actually in a couple patients with adenomyosis, but and they both got pregnant. But just as an end of 2, this is very
Compaction and timing for measure compaction have been answered before. Can compaction mean decrease of thickness between end of estrogen and the time of embryo transfer? What is the best time for transfer of blastocyst after starting progesterone? And the best supplementation, okay, this has been answered. When Dr. Botros will speak, Botros will speak at the end, how to prepare PCOS patients? PCO.
For whom? Buttress or?
No, it's for you and David.
Well, I don't think it's any different.
How do you prepare?
You have to use hormone replacement or else letrozole for a modified natural cycle.
Yeah, you can definitely use natural cycle in a patient with polycystic ovarian syndrome because they are not ovulating in their own. Either you have to induce them or you have to use hormone replacement cycle.
Yeah, I have a rapid question for Dr. Casper. Dr. Casper, at your elegant study, did you find a difference in compaction rate with regard to the endometrial thickness at start of using progesterone?
Yes, so the thicker the lining at the end of the estrogen phase, the more the chance of compaction.
Okay.
And we didn't find, as I told you, 7 to 8 millimeters is not good. We had an increase in pregnancy rate with compaction if the starting thickness was 8 or more millimeters, but it was even better if it was 11 or more millimeters to start.
Great. And did this affect the pregnancy rate?
Yes, pregnancy rate was higher if it started at a higher endometrial thickness at the end of the estrogen, and then compacted. Yeah.
Yes. And the second question, Professor Hassan, for the whole panelists, I think we can respond to it at the end. How many days of progesterone you use prior to embryo transfer for day 5 blastocyst? Is it 6 days or 7 days? We need the personal experiences rather than a bunch of publication we can read
for
with
us,
different opinions.
For us, 5.
5, yes.
For us, 5. For us, 5 days. 5 days. We used to transfer at 7, then 6, then now 5.
Okay.
Professor Casper?
6 days for us.
It might be interesting to say that
Mahdi?
Dr. Hassan, that I had the opposite
Peter, I'm
experience.
sorry.
Yeah, it's just interesting to comment, and I'll comment more at the final conclusions part, that we used to transfer at the day 5, and then moved it to 6, and then we moved it to 7. And yeah. So
Okay. Iman,
Okay, thank you. Thank you.
to compare, most of them, concluded that day 7, which we use now, is lower, actually not higher. But it has just been our retrospective evaluation that day 7 was higher than day 6. And then when I get a bit worried, I go back to day 6. So it shows you the level of science is limited here. Yeah.
This is interesting, huh?